Okay, well, I think in the interest of time, I might start saying some of my housekeeping messages at the front end. Obviously, I'm very pleased to welcome everyone again to another one of our interactive virtual expert panel discussion meetings, and this time on the very important topic of allergy immunotherapy. If you haven't met me before, my name's Dr. Martin Rees, and I lead medical affairs in the Asia Pacific region for Cellogene's career. And yeah, my role today is I've facilitated the organisation of the webinar. And as I was explaining just now, I'm just going to take a few minutes of your time to, with a bit of housekeeping at the front end. As per the instructions on the slide, everyone's been very well behaved. That's great. We just want to keep everyone with their video switched off and on mute during the beginning of the webinar. Towards the end of the webinar, we're going to have an interactive Q&A session. But throughout the whole webinar, we're encouraging everyone, if they haven't familiarised themselves yet where the chat function is, please open that and keep that live during the whole presentation, and use that to add your comments and your questions at any time. I just need to, yeah, anyone who's joined and hasn't unmuted themselves, just make sure they keep themselves on mute. So yes, to add your comments and questions at any time, Richard is going to be monitoring those comments and questions and be collating those and exploring those comments and questions in an interactive Q&A session. So apart from the housekeeping, one important point is that as per our last webinar on grass pollen, there was significant interest from people who were unfortunately not able to join us. They've requested that in follow-up a recording be made available. So we are recording this session today, and an edited version will be made available in follow-up as requested. And with no further ado, I'm going to shift to the next slide. And introduce the topic and our speakers today. I'm very, very pleased indeed to introduce two very well known experts to everyone on the call today, I'm sure, Professor Connie Katelaris, who is the head of unit at Campbelltown Hospital, the Immunology and Allergy Unit, and also Professor of Immunology Unit at Western Sydney University, who will be giving a plenary session today, also Associate Professor Richard Lowe, who you're very well acquainted with, who's had a long-standing interest and expertise in anaphylaxis, who's going to be chairing the interactive Q&A session at the end. As per the timings here, we're looking to finish the session within the hour and not too far beyond that. We anticipate we might not get through all the questions, but we'll try to follow up as individually as appropriate if we aren't unable to get through all the questions. In terms of the topic as described is trying to capture both the content within Connie's plenary, which is very much focused on the evidence and the guidelines, and also trying to capture also the scope of discussion which may occur during the Q&A, which we anticipate will have questions which are specifically around local practice and local considerations, and hence the use of the phrase local insight. The panelists at the very front end, before we get to the medical and scientific discussion, have made time for Jonathan Ryan, our General Manager for Asia Pacific region, to make a few words at the start which are relevant to the supply of Venom Immunotherapy, and then hence that has relevance to the medical and scientific discussion. So I'm going to hand over to John right now, if he can put himself visible, and here we are, John.
Thank you, Martin. Can you see me and hear me?
We can.
Fantastic. Well, thanks, Martin, and also thank you very much to our speakers this evening. So I just wanted to say that from a Cellogene's career perspective, as the supplier of Venom Immunotherapy products into Australia and New Zealand, we're really keen to be part of the discussions with the ASCIA community about how these products can be best used to improve lives of patients affected by venom allergy. And we also hope to contribute some insights of our own. So as you can see on the slide here, I wanted to start with an update on the manufacturing situation, specifically at JHS in the United States. And JHS forms the critical link in the supply chain for these products because they've been the single source of the Venom powder since 2018. And during that time, since that time, they've invested significantly in 2 new production lines for Venom products. The particular piece of equipment at the heart of the process is a lyophilizer, and that's the example of the picture you can see in the middle of the slide here. And in a particular effort to bring the capacity forward as soon as possible, GHS has been working with the FDA to approve their clinical trials materials line for commercial production. And I'm happy to report that this process of validation with FDA was actually completed at the end of last week. This line has a larger capacity than the previous commercial production line, and the annual expected output is about in the range of 1.5 million Venom doses per year. This is expected to increase the supply availability outside of the US market, which is obviously critical for us, by about 30%. And we expect to be in a very good position to increase supply locally very soon. The first commercial batches from this line are expected to be released as early as next week. Rest assured, we already have orders in place with JHS, and we will send out communications on progress and specific timings for local availability as these progress. Next slide, please, Martin. And my final slide is one which we certainly find extremely interesting, and hopefully one which generates some discussion during the webinar this evening. It shows the different rates of honeybee immunotherapy usage across Australia and New Zealand, which, as you can see, vary considerably. So specifically in the chart here, we have in the grey area, the population of each geography. So for example, New South Wales, about 7.5 million population, South Australia, 1.7, for example. In the red bars, the number of PBS or Pharmac prescriptions dispensed for honeybee during 2018 in each region. And we chose that year because that's a year where both sets of government data overlap across Australia and New Zealand. And in the yellow bars, we've calculated the rate of prescriptions per million population. And you can see that they really are quite widely differing. So for example, Western Australia and New Zealand seem to have a much higher rate of prescribing per capita than Victoria or Queensland, for example. And so we're certainly very keen to understand the reasons why that might be the case, and facilitating discussions like this around best practice with everyone connected to this conversation moving forward. So again, thank you very much everyone for attending, and Martin, I'll hand back to you.
Thanks very much, and it's my pleasure to hand very quickly over to Connie, but reminding everyone, of course, to keep your chat open. As comments and questions do occur to you during the presentation, please add them to the chat, which Richard will monitor. And I'm going to give you, Connie, if I can find you, it's the other Martin Rees, so you should have control now.
Thank you, Martin, and good afternoon, everyone. I am really looking forward to some great discussion on this topic, as we don't often get the opportunity to spend some time thinking about the intricacies of venom immunotherapy and stinging insect allergy. And I'm sure there'll be many insights and differing opinions that we can share towards the end of the presentation. So to start, I'm going to present the collected wisdom from the international guidelines, and then Richard will expand on one or more points before we hear from all of you. Now, the guidelines I'm referring to include the European Academy of Allergy Clinical Immunology, the British Society of Allergy Clinical Immunology, the American Practice Parameter, and our very own ASCIA guidelines, which is the most current of all of them. In relation to this presentation, I have no disclosures. So I would like to spend varying amounts of time on the, sorry, I'm having trouble controlling the.
Sorry, Connie, it's Martin again. Let me just try that once more.
Just go back one.
Yeah, accept all requests. So if you try now. Does that work better for you? So, Connie, if you're happy, I will advance the slides for you. So just ask me to advance and I'll advance.
All right, can you go back then?
Yep.
Back, yep. So forward. Okay, so we're going to cover a little bit of background, diagnosis, the delivery of venom immunotherapy, some of the contraindications, high-risk cases, and spend a few minutes talking about tryptase and the importance of mast cell disorders, as this has become quite topical. Next, please. So the prevalence of sting allergy, according to one of the more recent surveys, is of about 7.5% throughout Europe in the adult population. USA data suggests it's about 3%, and this is what's often quoted for Australia as well. Next. Many of you will be familiar with this data that's taken from Ray Mullins and colleagues' paper presented a few years ago, where they examined the Australian Bureau of Statistics mortality data looking at anaphylaxis fatalities. And they found that the leading cause of fatal anaphylaxis was medication and insect stings, most commonly in adult males aged 50 or more with multiple comorbidities. Sudden cardiovascular collapse was the most common reaction to Hello, Martin, it appears that I was muted.
Sorry, proceed.
Thank you. So as I was saying, sudden cardiovascular collapse was the most common reaction to medication and insect sting as a cause of fatal anaphylaxis. Honeybee stings account for most of these cases, and unfortunately, about a third of those dying had experienced previous sting anaphylaxis. So it begs the question as to why they were not seen and offered immunotherapy. Now, deaths occurred most commonly at home, in rural areas or on farms, and for those tending or disturbing hives. Next, please. Just want to spend a couple of minutes talking about taxonomy. We're talking only about bees and wasps this evening, and these belong to the order Hymenoptera. What we're interested in are the subfamilies of Aponae and Bombinae, and this is where we see the species of bees, honeybees, Apis mellifera, which is the predominant species we're talking about for Australia and New Zealand. Apis cerana, or the Asian or Eastern honeybee, has arrived on our shores. We don't know a lot about it, but the venom is probably highly cross-reactive with Apis mellifera. The bomba species are the bumblebees. Now, if we go over to the subfamily of Vespinae and Polystinae, we have the ones that are of interest, the Vespula, which contains the species Vulgaris and Germanica, which are the yellow jacket, also called European wasp. And then within Polistes and Rhopalidia, we have a variety of paper wasp species. Now, in Australia, there are probably over 1,500 native bees, but these are often solitary and they're very non-aggressive and less likely to sting. However, allergic reactions have been reported. We know very little about their venoms and they're not available. Similarly, there are native paper wasps, and again, they're less aggressive than the introduced species. Next slide, please. The important ones here are shown pictorially. So we have the European wasp or yellow jacket. It was introduced into Australia in the 1950s, first landing in Tasmania, and within 20 years had spread into Victoria, South Australia, New South Wales, and Western Australia, and it's particularly firmly established around the Sydney region. Polistes species are the common paper wasp, and they're found throughout Eastern Australia and Western Australia, especially around Perth. Honeybee is widely distributed around the coastal area, of course, and bombus or bumblebee is only found in Tasmania and New Zealand. Next slide, please. So throughout, I'm going to have a few questions and answers just to help you focus your mind on some of the salient features. So next slide, please. So what is the most common stinging insect allergy that we see in Australia? Paper wasp, European wasp, honeybee, bumblebee, or tick? Next slide, please. Well, if we go on the Venom Immunotherapy kits that are written for on the PBS, we can see that honeybee far outweighs the two available wasps, with paper wasp second and yellow jacket behind. So many, many more honeybee immunotherapy kits ordered than the wasps in Australia. Next slide, please. We should review the reaction types following a sting. There is the expected local reaction. This is usually transient, although it can last for several days, and it generally resolves without treatment. Then there is a large local reaction, which by definition must meet an area of induration of greater than 10 centimetres, peaking at 24 to 48 hours, and then subsiding. Now, this is usually an IgE-mediated late phase reaction. The risk of systemic reaction in patients who experience large local reactions is debated. In the old literature, it's suggested to be around 4 to 10%, although there are studies that suggest there's no increased risk. More recent studies suggest that the anaphylaxis risk following a large local reaction is less than 5%. We move on then to the cutaneous systemic reaction, which is defined as urticaria and/or angioedema, which occurs remote from the actual sting. Next slide, please. And then we have the generalized systemic reaction, or anaphylaxis, in its various grades. This occurs very uncommonly in children, between 0.4 and 0.8% of children, and as I said, around 3% of adults. Now, following a systemic reaction, there's a 40 to 60% chance of a re-sting reaction, so it's not 100%. Most common cardiovascular manifestation is hypotension, and laryngeal edema and circulatory failure are the most common causes of death from anaphylaxis from a sting. And we shouldn't forget there are some other rare, interesting, non-IgE mediated syndromes. Next slide, please. And they are listed on this slide, and they include various neurological, hematological, and respiratory reactions that have got nothing to do with allergy. Next slide, please. So one of the important exercises we need to go through when we have a patient before us is to assess and stratify the risk of anaphylaxis to stings. Now, those who are at high risk include those who have had a previous severe reaction. Honeybee stings carry a greater risk than wasp. Male, as we've already heard, and in the middle to older age group. Where there is a lack of urticaria and angioedema as part of the reaction, when there are multiple or sequential stings, patients on ACE inhibitors, and those that have an elevated basal tryptase. Next slide, please. Conversely, those who are at low risk are patients who have a cutaneous systemic reaction or large local reaction, specifically those that are asymptomatic that have sensitization. When a patient is undergoing VIT and after they have had a course of VIT, hopefully their stratification of risk returns to a lower level. Next slide, please. So who should we treat with venom immunotherapy? Well, it should be offered to all who have had a systemic reaction to the insect sting and have a positive measure of specific IgE. Certainly, we should consider the high-risk patients that I've outlined already, patients who have a high basal tryptase and those with mastocytosis, and also those with severe cardiovascular disease as a comorbidity, because they are they're at the greatest risk if they do sustain a sting reaction. Next slide, please. Now, we shouldn't offer venom immunotherapy to those who have a positive skin test or in vitro test, but have no history of anaphylaxis. Now, this is an issue that is now debated, certainly in the American practice parameter. It's now suggested that those who have a large local reaction or cutaneous reaction, either a child or adult, may be offered venom immunotherapy, depending on the impact of these reactions on their quality of life and their level of anxiety and their level of exposure. So if they're having regular, troublesome, large local reactions, as you might see in a beekeeper, or for those that have cutaneous reactions, the Americans would say that they would be candidates. The Europeans and the Brits disagree with this opinion. Patients who have had a systemic reaction, even a convincing one, but have negative tests of specific IgE on 2 occasions, we shouldn't proceed with VIT because we don't know the venom involved. Next slide, please. Now let's look at the risk factors for a systemic reaction, and we're talking adult population here. So patients who are sensitized but haven't had a reaction, well, their risk is really unknown above the population risk. In more recent studies, it's been demonstrated to be around 5%. In the old literature from the 80s, it's ranked as between 10 and 15%. For those who have large local reaction, as I've said, the risk of a systemic reaction varies depending on the paper you read, anywhere between no risk to 5 to 15%. And those who have sustained a systemic reaction, the risk of another systemic reaction is 40 to 60%, but it's increased significantly if it's preceded by a sting in the previous 2 months. Remember that the level of specific IgE doesn't predict likelihood or severity of future systemic reactions. Next slide. There are factors that modify severity, and these include age, which we've referred to. So very young children, it's very rare to see near-fatal reactions. Older patients, males in particular, a much bigger risk. Comorbid cardiac and respiratory disorders carry an increased risk, as does having a raised baseline tryptase. So about 25% of those with severe reactions, meaning loss of consciousness or cardiac arrest, have an elevated tryptase, and patients with mastocytosis. Next slide. Well, diagnosis depends very strongly on the history. So one has to be convinced that an allergic reaction has occurred. And we do rely on history strongly for insect identification, although sometimes it is impossible to gauge. We all know that a bee sting can be left in situ, but it is not a strongly discriminating factor. We rely on skin tests and in vitro tests. Component resolved diagnostics are now available and may be used occasionally to discriminate where the issue of cross-reactivity is one that needs to be resolved. Basophil activation tests remain a research tool, but in many centres in Europe, this is now being added to more usual clinical testing. And serum tryptase we'll talk about later. Next slide, please. So if we run through what the guidelines say, in the UK, the skin test is held as being the gold standard. They maintain that there's greater discrimination between bee and wasp reactivity on skin tests than one can get from in vitro test. The reason for this is that the in vitro test often picks up non-important cross-reactivity because of the cross-reactive carbohydrate determinants, and that the skin tests correlate better with the clinical history. Skin testing is done with 1 to 100 micrograms per mil, and if it's positive at 100 micrograms, one accepts that as a diagnostic, and otherwise they go to intradermal test with a positive test somewhere between 0.001 and 1 microgram per mil of venom. The states recommend skin testing up to 100 microgram and then intradermal testing positive 1 microgram or lower. They state that the role of component testing is not yet well defined, and that one may use measurement of IgE to multiple recombinant allergens to distinguish particular between vestibular and Polistes sensitization. The IARCI guideline doesn't discuss diagnostics. Next slide, please. Of course, anyone who's sustained a systemic reaction to a stinging insect should be referred where there is expertise in this part of practice. These patients need careful evaluation, investigation, and counselling. Prescription of an adrenaline auto-injector should be made with careful education about when and how to use, with early use of adrenaline at the time of reaction being taught. Education about avoidance measures for stinging insects also important. And then obviously we need to undergo diagnostic testing to be able to confirm and or identify the insect responsible so that immunotherapy can be considered and discussed with the patient. Next slide. Let's turn now to the nitty-gritty of venom immunotherapy. Next slide. So the purpose of immunotherapy with venoms is twofold. Firstly and primarily, it is to prevent anaphylaxis and the risk of death from a sting. And second, and importantly, it is to relieve anxiety. Anyone who sees these patients knows that a proportion of them become highly anxious about being outdoors. They become very nervous about their job if it places them at risk. And many of them need counselling after a near-death experience from a sting. So this is an equally important indication for immunotherapy. Next slide. Immunotherapy with venom for stinging insect hypersensitivity was introduced in 1979 following the studies that demonstrated a lack of efficacy of the use of whole body extracts, which were used up until that time. Now, the guidelines that have been published since that time, I've already alluded to. There's the British ones, which are fairly old now, from 2011, the European ones that were updated in 2018, and the American practice parameter that was first published in the 1990s and the latest version updated in 2016, and our own guideline in 2019. It is important to recognise, though, that in this field there are very few double-blind, randomised controlled studies. And there's a very great reliance on observational studies, case studies, basic laboratory reports, and expert review articles on which these documents, these guidelines have been developed. And I'm going to highlight the things that have changed or evolved in these guidelines. Next slide, please. So we've heard about the venom extracts available in Australia and New Zealand. There are freeze-dried whole venom of honeybee, paper wasp, and yellow jacket, and it's a Hollister Steer product. In Europe, there are a number of extracts available. There are non-purified aqueous, purified aqueous, and a depot preparation. Next slide, please. So, time for a question. Dosing schedules. Next slide. What is your recommended starting dose of venom? Next. 0.001 microgram, next. 0.01, next. 0.1 or 1. Next slide. And what is the top dose for maintenance that you aim to achieve? 50 micrograms, next. 100 micrograms, next. Or 200 micrograms. Next. Next. We have a number of dosing schedules. Next, please, Martin. There is the ultra rush, which is achieving maintenance over hours. To my knowledge, in Australia, very few people do this. Modified rush, which takes days to achieve maintenance, is popular, and it's certainly my preferred mode of dosing. And then there's the conventional, which achieves maintenance dose over weeks or months. Next. Whichever dosing schedule is used, there is a period of updosing followed by maintenance. Now, the starting dose for the UK recommendation is 0.01 microgram, but with the American practice parameter, it's now considered that 1 microgram is safe. I've certainly not had problems at the very, very low doses of 0.001 or 0.01, and it's now my practice to start at 1. Maintenance phase, there is some discussion here, and it'll be interesting to hear those on the webinar. 50 micrograms has been considered perhaps sufficient as reference in the American practice parameter, referencing a study from Western Australia, and it'd be good to hear from those authors, and from a Greek study, that this may be sufficient for children. 100 microgram is the one that is most usually aimed for, and this is historical because the study that established purified venom immunotherapy used 100 micrograms. It was the only dose that was used for maintenance, and it was derived with the thinking and understanding that a sting delivered about 50 micrograms of venom. So if you went for double that, you would get protection. Now, you know, in the light of the 2000s, we know that that is not particularly accurate, as a bee sting can vary anywhere between 50 and 150 micrograms. But empirically, 100 micrograms has served us reasonably well. Occasionally, a higher dose is recommended, and that is particularly so for patients who have had reactions during the immunotherapy program or have had a field sting and have reacted, and then one would want to increase the maintenance dose. Next slide. How long would you continue with a VIT program? 1 year, 3 years, 5 years, or indefinite or lifelong? Okay, next slide, please. Well, if you stop after 1 year, the relapse rate is 20 to 30%. Next. The UK guidelines say that the data suggests 3 years and that anything beyond that is devoid of evidence. IARCI tends to agree with that opinion. The American guideline states that for some people, 3 years may be adequate, but for most you would want to continue next to 5 years. Next slide. The UK guidelines say that we have no evidence at all, even for patients with mastocytosis or raised tryptase, to consider indefinite therapy, and until the evidence becomes available, it's not their practice to do so. IARCI says that for those patients, one might want to consider indefinite, and the Americans come down more strongly on that side. Next. Next. Keep going. So 3 years may be sufficient for children and for those with, you know, cutaneous systemic reactions that you've decided to undertake immunotherapy in. 5 years is better than 3 years for the longevity of protection, but the evidence for this is weak. Next. The longer treatment is recommended for the high-risk patients, at least by the Americans, and it's considered by others. Next. For frequency of injections, it's now considered 4 weekly for the first year, moving to 6 weekly in the second year, and 8 weekly in the third to 5th year, perhaps being able to move to 12 weekly after 5 years. But this is an evidence-free zone, and this is expert opinion only. Next slide. So what about the effectiveness of VIT and the level of protection that you can counsel your patients about? Well, with honeybee venom immunotherapy, it changes your risk from 40 to 60% to a protection of 77 to 84%. Next. With the Vespid, it's much higher, that you can expect, you know, in the 90s for protection. Why the difference? Next. Well, the amount of venom delivered by a bee is much higher than with wasps, and it's a more consistent sting, sting after sting. The second reason is that there is probably underrepresentation of 2 of the major bee venom allergens in the present honeybee venom immunotherapy. So these may be the reasons why we see less protection following bee venom compared to the Vespids. Next. How does one gauge the effectiveness of your venom immunotherapy? Well, the Europeans have been very keen on doing a sting challenge to gauge whether once you've reached maintenance, you have a patient who is protected. And they still state that the sting challenge is the gold standard. And from this, they determine if a higher maintenance dose is required. They say that the reliability of this to monitor VIT is high. This is in disagreement with both the British and the American views. The British guidelines state that the negative predictive value of a deliberate sting challenge is poor, and they certainly don't recommend it for routine clinical practice. In the American practice parameter, they say it's neither consistently reproducible nor without risk. And in fact, there is a study that showed that 20% of patients who don't react to a sting challenge will react after a second challenge. And that was data from the 1990s, and they say it's not recommended. Next slide. So when is protection achieved? If we go back to the Europeans, a sting challenge is tolerated in 89% 1 week after reaching maintenance dose with either rush or conventional. So they feel that protection is achieved at that point and say that for confirming that a sting challenge is useful. This is not common practice by any means, but it gives us some insight into the fact that once you achieve maintenance, you can tell your patients that the protection is in place. Next slide. Compliance and adherence to any immunotherapy is something that we talk about and worry about, because we know from many studies now that for aeroallergen immunotherapy, compliance and adherence is abysmal, such that by the third year, in one Dutch study, only 17% of people were still continuing on their immunotherapy. This is in contrast with venom, and it's easy to understand why. Compliance and adherence is extremely good, as you can see by the figures here, because the risk of anaphylaxis and possible death is a major motivator. Next slide. So all guidelines agree that using antihistamines as a pre-medication for immunotherapy is useful for managing large local reactions and cutaneous symptoms that may follow an immunotherapy injection. But it is important to understand that they do not prevent the possibility of a systemic reaction to an immunotherapy injection. Next slide. Treating more than one venom is also a debatable issue, and it'll be interesting in people's views here. The British and the Europeans state that it is rare that you would need more than a single venom unless there is a clearly documented history of a reaction to two different types of insects. Along with their general view on immunotherapy, the Americans recommend venom immunotherapy to all venoms giving a positive specific IgE. Now, I've already alluded to the problem of possible cross-reactivity, which is unimportant clinically, and so that becomes an issue. But in the USA, many patients receive 3 venom immunotherapy. Next slide. Long-term follow-up studies inform us that in adults, the cumulative risk for systemic reactions is of the order of 5 to 15%, anywhere from 5 to 13 years after cessation of an immunotherapy program. Resting reaction rate is low, 1 to 5 years out from Vespid immunotherapy, and that's data from the 1990s. You'll see throughout this presentation that a lot of the data is from the 80s and 90s, and much of this hasn't been repeated more recently. In children, we have good data from David Golden, published in the early 2000s, showing that there was only a 5% rate of systemic reaction 10 to 20 years after venom immunotherapy was completed, compared to a 32% rate if a child had not been treated with VIT, having had a systemic reaction. Next slide. Side effects and management is something we need to consider. So the risk of a systemic reaction during VIT is reported anywhere between 8 to 20%. It's greater with honeybee venom. Rapid dose increase is a weak risk, and higher baseline tryptase is a weak risk. Next slide. So the use of omalizumab is known by many of us to help us in those difficult patients where it's difficult to initiate VIT without systemic reactions. This is something that is reported in small case series or case reports. There is no consensus on protocols. The British say don't do it because the evidence is not great enough. Others refer to it as a possibility, but procedures vary greatly. Overall, though, the case series reports are positive for the use of omalizumab to help establish VIT. Next slide. Would you prescribe VIT if your patient was on a beta blocker or an ACE inhibitor, or receiving treatment for a malignancy or having an exacerbation of lupus? Next slide. We know that these are some of the classic contraindications for immunotherapy in general, but there has been a reconsideration of this. Importantly, with severe cardiac disease, we know that these people are the ones most at risk of dying from sting anaphylaxis. So based on a risk-benefit analysis, this is not a contraindication. So if beta blockers and ACE inhibitors are required for managing severe cardiac disease, they in themselves are not a contraindication. Few data on pregnancy. It's generally safer to continue than to stop, and with all immunotherapy, don't start it in pregnancy, but one can continue. Autoimmune disease, there's very little data for this, and really autoimmune disease well controlled is not a contraindication. Malignancy, again, there's really no good data, but there's no evidence of a bad effect of chemotherapy on immunotherapy or vice versa. So one would make this decision dependent on the burden of treatment versus benefit. Next slide. Beta blockers has had a revision in that all of the guidelines now suggest that it's not a contraindication, that you continue it with informed consent. The level of evidence is grade 4. The benefit of VIT will outweigh the risk of beta blocker treatment in those with severe cardiovascular disease. The UK guidelines are the most cautious, saying that when it is essential to carry on with beta blocker, these patients should have glucagon available. Next slide. ACE inhibitor, similarly, none of the guidelines say that this is now contraindication. And in fact, there's been one study that has suggested that no systemic reactions for people receiving immunotherapy on ACE inhibitors. Next slide. Raised serum tryptase levels. Do you think it predicts severity of sting reactions, predicts increased reaction rates within venom immunotherapy, defines a diagnosis of masto, mandates investigation for a mast cell disorder, or mandates lifelong VIT? Next slide. So we know that tryptase will rise during anaphylaxis following a sting and will return to normal within 24 to 48 hours. And we need proper collection to have a reliable result. The high peak levels are certainly seen with perioperative anaphylaxis, intravenous drug anaphylaxis, and venom. And it has been described as a predictor of sting reaction severity. Next slide. An elevated basal tryptase is a risk for severe anaphylaxis before, during, and after VIT. Next slide. So patients with mast cell disorders and sting allergy do demonstrate severe anaphylaxis with predominantly cardiovascular manifestations. So this history should alert the physician to investigate for a mast cell disorder. Now, 1 to 8% of patients with severe sting allergy have a mast cell disorder, compared to mast cell disorders, 1 in 10,000 cases in the general population. The study that has informed us about this, the Bonadonna study, makes the claim that a systemic reaction following sting in those with a mast cell disorder mandates lifelong treatment with VIT, and that's what the American practice parameter refers to. this is disagreed with the UK. I'll skip over that. We've already dealt with that. Next slide. Iaki says the mastocytosis is a risk for development of venom allergy and for severe reactions, and that adverse reactions during immunotherapy occur more commonly in masto, but it is generally well tolerated. And that while there's no evidence that VIT should be continued indefinitely, you consider it in those that have had a very severe reaction or have elevated tryptase, so really sitting on the fence. In the USA, the guideline spends a lot of time on tryptase and mast cell disorders, and you can refer to this. So the important points here is that insect-sting allergy in patients with masto are common in 25%, may be the presenting sign of indolent masto, and it's the most common cause of anaphylaxis in mastocytosis. The greatest risk with VIT is in the build-up phase, and honeybee carries a greater risk than wasp, just as it does for others. Next, please. So VIT continues to be an evolving field. However, there are many questions that require further studies with rigorous trial design. So for the younger immunologists, this is an area that needs more work. There are lots of questions. We need better evidence for the optimal duration of therapy. We need evidence about the use of more than one venom. It'll be great to have biomarkers to predict those at greatest risk. And we need more long-term studies for the level of protection after cessation. Next slide. So these are the guidelines I refer to. And with that, I'll hand over to Richard, and thank you for your attention.
Thank you, Connie. It was a brilliant presentation. I've got a few questions. One is from James, asking whether asthma is a risk factor for severe and or potentially fatal venom anaphylaxis.
Respiratory disorders in general are listed as one of the risk factors, and I think, you know, common sense would inform us that uncontrolled asthma would have to be considered a risk factor. Yeah, I would agree with that.
I think we were forewarning this, a question from Sasha about D EpiPen. So I guess removal of prescribing EpiPens, there's great variation in practice, and
yes,
she's certainly very interested in what you do.
Okay. Look, I don't think there's any right or wrong, and I would preface my remarks by saying this is always a conversation with the patient, and the patient helps you decide this. My view, and it's not by any means the only view, I would give an EpiPen to any patient who has had a systemic reaction following a sting. For those who are undergoing Venom Immunotherapy, I prefer them to have their EpiPen while they are undergoing immunotherapy in the first 6 to 12 months. Whether they continue to carry it or not is something that we would discuss. Certainly, the guidelines suggest that they could give up the EpiPen while on maintenance VIT. Following VIT, people vary in their attitudes towards EpiPens. For me, it is stratification of risk. If somebody has had a near fatal sting, regardless of VIT, I would encourage them to still have it. If they live in rural and remote areas, if they are beekeepers and insist on continuation of keeping bees, if they have a high tryptase, despite the fact that you've taken them through venom immunotherapy, I would prefer that they had an EpiPen. So I'd be very interested in other people's practice, but that would certainly be my practice.
A question or a comment from Maria Say from Allergy and Anaphylaxis Australia. Do you think all the appropriate patients, I guess, are being referred appropriately to allergists? I guess that's one of the slides from Ray's data, that 30% of patients who died had a previous severe reaction and was not on immunotherapy.
So that's a usual Dorothy Dixer from Maria. Of course, the answer to that is very likely no, and Ray's data would speak to that. So I think it is important that we educate our GPs as to the importance of a patient having a review with an allergist immunologist after a systemic reaction to a sting, because of the risk that they carry with subsequent stings. Now, many GPs are very able to counsel patients correctly on this and recognise those who have greater risk. But I think a patient deserves counselling by somebody who understands this field and can talk to them at length about the pros and cons of undergoing prolonged therapy. And again, it comes back to stratifying risk according to the patient's lifestyle, occupation, place where they live, and the type of reaction they've had. I think every patient having had a systemic reaction now should have a baseline serum tryptase done, because I think a high tryptase immediately identifies those that carry a greater risk, and I think that mandates referral.
I was actually going to ask you about that. We've been doing tryptase in Perth for quite a long time in children, and we have not picked up a mastocytosis, but we've picked levels up around 11, 12 without any other features. Is there any value in c-KIT studies? Where do you go with that level? Yeah, really, and I noticed in the email discussions that's been going around, they've been talking about c-KIT studies.
I don't have an answer for you. It's something I think, you know, people would have a variety of opinions around. I suppose if that person had a sting, it'd be really important to see if they have an elevation around the time of the sting. We know that there are families that have hypertryptemia, but we know that they probably carry an increased risk of more severe systemic reactions. To your question of whether they have an underlying mastocytosis, I think in a child without any cutaneous sign whatsoever, having examined them carefully, I think that's very unlikely, but I suppose you have to look at each individual.
Great. People are wondering why I'm squinting. The chat is very small. I'm trying to look at it. How much venom in was sting, and what is the final dose of was venom immunotherapy? Is it the same as 100 micrograms?
Yes, we've traditionally used the same, but an average wasp sting can deliver venom as low a dose as 17 micrograms, and usually not much above 20 to 30. So therein lies a big difference, and probably explains why wasps are less represented in the very severe life-threatening end, and why they have a better outcome with venom immunotherapy. And I suppose to extrapolate that, you could see that really for those at very high risk of a resting anaphylaxis with honeybee, you may want to push the dose higher. And this is an unknown. We don't do sting challenges for good reason. They have poor negative predictive value, and one sting challenge doesn't prove that a patient is controlled. So we don't really have a good way except following a patient and assessing them if they've had a field sting while on immunotherapy.
A question from Anna. In terms of starting dose of 1 microgram rather than the lower doses, adult and pediatric the same in your experience?
I've done very few pediatric patients, so I wouldn't take my experience on that. But the Americans are saying that 1 microgram starting dose looks very safe, and it would certainly simplify things a little to start at that dose.
There's a question, and Bryn may wish to unmute. Could you clarify, you said roughly 80% responded to venom immunotherapy, and then the risk of systemic reaction during long-term follow-up is 5 to 10%. Just not sure how these two risk estimates relate to each other.
That's after cessation. That's period after cessation. That data comes from following patients up after the cessation of immunotherapy. The risk is while they're on maintenance. The protection of 74 to 80% with honeybee is while maintenance is being administered. Once you stop venom, the risk of re-sting reaction increases slightly over time.
Narinda's made a comment that was sting multiple times versus a bee. I guess it's a comment. Do you want to say anything more to that?
No, I mean, they can do that because they don't die and lose their stinger as do the poor bees.
Damien asked a question, is that the venom expiry is 6 months after reconstitution. If you change patients to 6, 8 weekly or even 12 weekly as recommended, then does that actually save things? And what do you do with the venom? You'll end up throwing it away, some of it.
Yes, well, the company may wish to address this. It is a dilemma, but I think, as with most things, the expiry date is usually very restrictive, and we know that many things, if stored correctly, retain their potency for a lot longer. But, you know, I can't advise people about that. That's a decision the clinician will make.
And some of our colleagues also stated that they pool patients, and again, it's the issue of using one vial for multiple patients, and that way you can utilize and not waste bee venom.
Yeah, that's right. And that's fine for clinics where you have multiple patients.
I wonder, because Martin, could you show the slides for WA? WA uses 50% of Australia's bee venom extracts there. So this is the data that was given, and South Australia, but looking at the data, we use 50%. So I thought, looking at honeybee distribution, we might have a lot of honeybees in WA, but when you look at the data, we seem to have, similar amount to Australia. Next slide, thanks.
Eastern Australia, you mean?
Eastern Australia, yes.
You are still part of us.
Yes, definitely. We are using less bee venom compared to New Zealand. That's their data on file, and whether something's changed as well. Initially, I thought, there is a problem with bees dying, but New Zealand actually has more of a mite problem killing bees than we have in Australia. So I thought we might have a lot more sunshine in WA, and that's why we're out. And, this is pre-COVID. Go to the next slide. And looking at, this is envenomation, looking at emergency room data. Perhaps there was more envenomation, but that's a question. We don't have an anaphylaxis register. But if you look at the yellow bit, that's actually wasps and hornets and bees. And if you look at WA, we're not that much different from the rest of Australia in terms of envenomation. And the last slide, I think it's there, is looking, looking at sunshine. It doesn't look as though we've got more sunshine. So I don't know whether we are overutilizing in WA or something is different and how we're practicing. I know in WA, we use 50 micrograms as our maintenance for children. It's been routine practice since 1970s, before my time. And data that Dominic has published in New England Journal and Jackie, saying the efficacy seems to be very similar to 100 micrograms with a lot less side effects. And with the shortage, there's something to discuss.
So, I mean, there are more simple exclamations as how many immunologists per capita? Do you have a much better referral system? Have you done a better job at educating GPs to refer everybody? I mean, have you looked at those aspects?
We don't have the data, but that's one issue, is whether we're getting appropriately more referrals, or are we starting patients inappropriately or whatever, for more discussions, because we're using lower doses in our children, yet we're consuming more. sorry, I have to look at more questions. Tryptase, wow, 50%. Should Venom Immunotherapy, I guess, is how do we manage, whether Martin and John, I know we are potentially getting more bee venom. I'm very conscious of the time, but it looks as though we still have shortages. And there are a couple of questions, I guess, talking about how we manage this shortage. This is the ASCIA guidelines. And I know Bryn is on, you know, whether there is a coordinated approach on what we're doing. What are you doing, Connie, when there is a shortage?
So look, I think most of these are reasonable given unreasonable circumstances. I mean, it's just dreadful that we have shortages here, is the first thing I would say. And really, we've got to do all we can to lobby for this not to happen because our patients are impacted by it. So this is where stratification of risk comes in. I would certainly not, in a climate of you know, shortages, suggest venom immunotherapy for a cutaneous systemic reaction, for instance. But if somebody's got severe cardiovascular disease or lives in a rural and remote, they are graded as high risk, and that's, you know, I think stratification of your patient population as to whom you're going to start despite the shortages is really important. I know that, you know, the suggestion of increased interval, we don't have any firm data to inform this, given that we're now moving more liberally to spacing, especially after the first 12 months. I think it's not an unreasonable thing to do, but none of us have data to say that our patients are still as protected. That's what I say. There are a lot of holes in our data. We do these things out of necessity, not based on any evidence.
There's a question about the role of honeybee venom IgG to monitor responses to immunotherapy. Do you think there's a role?
No, I don't at the present time, and all the guidelines dismiss it as useful. Dismiss it as not being useful, I mean, yeah.
There's a question, there's a comment, I think, from our colleagues from New Zealand that public pediatricians with a special interest in allergy do most of the venom immunotherapy. I guess it's a comment perhaps explaining why New Zealand may be having an increased use of immunotherapy, perhaps greater access, as you mentioned, Connie, instead of to allergists, to pediatricians with interest in allergy. I'm not sure whether our colleagues in New Zealand want to unmute or say anything more about that. There's a comment, Connie mentioned that there's an underrepresentation of some honeybee components in venom immunotherapy, which may account for the lower protection. Is this an issue with extraction in the manufacturing process? And is there a way to correct this?
Yes, I don't understand why that's the case, but it's been found that APM3 and APM10 are the two that may be underrepresented. And when you look at the reactivity of IgEs from a variety of patients, you know, 50 to 60% of patients with bee sting allergy will react to those two proteins. So, you know, that could be an issue for some patients. I don't understand why they're underrepresented.
A question, a person presenting with anaphylaxis after a sting or bite of unknown insect, how do you approach it? And is there a role then for component testing when you get results that you are a little bit, find it difficult to interpret?
Well, I don't think you go to component testing at all. I think you need to do a specific IgE to all the venoms available and skin testing. They would be the two things. I mean, if they're negative, then I don't think there's any point in doing component. I think component is useful for helping you discern cross-reactivity and the the possibility that you have somebody who truly does have 2 clinical sensitivities rather than an in vitro cross sensitivity. So I would do in vitro to the 3 venoms and skin testing. And if they're still negative, well, then you can't proceed, but that patient would have the usual counselling of anyone having had an anaphylactic reaction, and they would be provided with an adrenaline auto-injector and told to come back if anything else happened.
A follow-up to the low FPM3 and FPM10 in Venom Immunotherapy. Is there a role for component testing to help predict success to Venom Immunotherapy, or whether the patient should carry EpiPens after Venom Immunotherapy is completed?
Well, again, I don't think that we have any science behind us to inform that. I suppose it is possible if you did component testing and these were patients who had high specific IgE to those 2 components, you might be more concerned about their risks despite immunotherapy. Obviously, they will have reactivity to other components, so there will be some benefit, but they may not benefit as much. So yes, it could be one way of determining. It's an expensive way of determining whether you're going to get them to continue carrying an EpiPen or not. But I think that approach, you know, has merit. It's not something I've done.
Thanks, Connie. I think we've reached the 1 hour, and I was wondering, thank you everyone, you know, for staying on. We had over close to 100 participants, and it's great that everybody stayed on. I wonder whether Martin wanted to say anything, but it was a wonderful lecture, Connie. Thank you very much.
Thank you, Richard.
Thank you, Stallions, for, you know, assisting in facilitating this.
No, thank you. I personally learned a lot, and I'm sure everyone else did. Just to very quickly to say thank you to everyone for your participation, and especially both our panelists and most especially Connie for putting all the effort into those slides. We're very interested in, obviously, in your comments that are already coming through in the chat, but in follow-up, if everyone would be willing, we will send a small survey to inform the conduct of future webinars similar to this. So with that, I wish everyone a good evening and thank you very much.
Thank you.
Everyone, and keep safe, everyone, especially in Victoria.
Yes.